Welcome to chapter 14. This is anxiety and anxiety disorders. Key terms that the chapter highlights that you should understand. These are the learning objectives that we will cover during this lecture. So, what is anxiety? The definition of anxiety is a vague feeling of dread or apprehension in response to external or internal stimuli. Um, it's a distinction from fear, where anxiety has no clear external threat, and fear is in a response to an identifiable danger. Normal anxiety is expected in our life. It can be beneficial by motivating us to have problem solving, and it typically resolves when the situation is addressed. Anxiety disorders um, can have behavioral, emotional, cognitive, and physiological responses, some symptoms and impact, panic without a reason, unwarranted fear of objects or situations, overwhelming worry, a significant distress affecting daily life, social interactions, and our work. And we're going to go over these disorders and related disorders like obsessive compulsive and PTSD are covered in chapters 13 and 15. So, anxiety as a response to stress. Um, Overview of the stress response, right? Stress is the physical and emotional wear and tear caused by life. Triggers can be life situations, problems, and goals that challenge one's ability to cope. Individuals differ. Some of us thrive under stress, while others really struggle. Examples could be public speaking, could be distressful for some and enjoyable for others. Other common stresses might be life events like getting married, having children, changing jobs, flying, or even encountering a snake. We have our general adaptation syndrome, which we'll go over more, but that talks about our alarm stage, our resistance stage, and our exhaustion stage. And really, it's just how the body reacts to physical stress and how the mind reacts to emotional stressors. So, our three stages. When we talk about the alarm stage, this is that stress signal that's sent from the hypothalamus to the glands and organs. Your key physiological changes is the adrenaline glands release adrenaline and norepinephrine, which provide fuel for the response. The liver starts to convert glucose to or glycogen to glucose to give the body energy. We then have our resistance stage, when this is when the body prioritizes defense mechanisms. So the digestive system will slow down to redirect energy. Lungs start to take on more oxygen, the heart starts to pump faster and harder, and increases oxygenated blood supply to muscles, providing us with our flight, fight, or freeze. If adaptation occurs, the body returns to normal, otherwise, stress will continue. In the exhaustion stage, this results from prolonged stress or unresolved emotional issues. The keys for this, we have a depletion of our body resources, we have continued physiological arousal, and this is going to lead to a decrease in our reserve capacities, leading to potential health risks like death. So our levels of anxiety, right? We just talked about the alarm stage, the resistant phase, the exhaustion stage. So now we're going to talk about how our autonomic nervous system works. And we have our sympathetic nervous system, right? Your CNS response. So your CNS activates the body's defense systems as a sign of danger. And this is when we're going to release those adrenalines, which is going to increase that oxygen intake. Our pupils are going to dilate, our blood pressure and our heart rate's going to go up. The GI tract is going to get diverted because we don't need that. We need it to go to the muscles, we need it to go to the brain, and that liver breaks glycogen down to give us that energy boost. And the parasympathetic nervous system is going to be active during the recovery phase. So it's going to restore body to normal after the threat's passed. So when we have anxiety, the effects, we have cognitive changes where we might have difficulty with our logic thinking because we're going to be trying to like run, hide, freeze. We're going to have psychomotor changes. We're going to have, with that, increased agitation, maybe some restlessness. Our physiological, you're having that increased heart rate, increased blood pressure, and tension. Adaptive responses. So we have positive coping mechanisms that can happen, where we can kind of hit and have the client do imagery or relaxation or deep breathing. And we're going to hit those adaptive responses to try to help bring us out of that alarm stage, resistance stage, so that we don't get into that exhaustion stage. And then we get a maladaptive responses where we're going to be in that resistance stage, not be able to hit it, and get tension headaches, pains, and eventually taxing to our immune system and things like that. So when we talk about our levels of anxieties, we have mild, moderate, severe, and panic. In mild, right, we're getting this alarms going off, but it's really going to be just enough to give us extra attention, increase sensory stimulation, and mild is motivation, right? So that mild is good because it's going to motivate you. Then we have moderate. So moderate is going to be worry, nervousness. This is when you're going to have difficulty concentrating, right? So mild, motivational, gets you ready to study for the test. Moderate is when you really studied for the test, but now you're sitting in the test and you're having moderate anxiety and you're really having a hard time reading your words because you're having difficulty concentrating. Severe is when we're having trouble thinking. You're going to start to have that tightening of muscles, increase in vital signs, really restless, really irritable, and then maybe even a little angry. And you do not want to take a test if you're having severe anxiety. And then panic is when you're going to hit that flight or fight or freeze response. Um, Vital signs are going to be infected, pupils are going to be enlarged, cognitive processing, focusing are going to be down. So, working with the anxious client, it depends what level your client is in. So, you really need to be able to assess and understand where they're at. But remember, we encounter clients in various stages of healthcare settings that potentially are having anxiety. So, think about your emergency rooms, your ICUs, your pre ops, your post ops. All of those clients can have different levels of anxiety. So if we have mild anxiety, we know that mild anxiety is making you motivated. It's going to be helpful for learning. It's going to be helpful for problem solving. And if a client has mild anxiety, they're going to be eager for information, which is going to make teaching them so much easier. Then we get to that moderate anxiety. This is when we're going to have difficulties concentrating. They're going to have wandering of attention. So you really need to make sure that your communication is very simplified. You want to use short sentences. You might have to do frequent redirection if the client keeps going off topic. When I think about moderate anxiety, I usually think about my post-op client or pre-op, right? They're in the emergency room. They're just told that they have appendicitis and they're like kind of moderately anxious that they're going to have to go in for surgery. Severe anxiety, this client cannot focus. They cannot take in new information. Your biggest actions is going to be staying with this client because their anxiety will worsen if they're left alone. You want to speak in a low, calm, soothing voice. You want to encourage them to do deep breathing, relaxation techniques. And if they're really restless and they want to walk, you can walk and talk at the same time to help kind of bring them down off that anxiety level. If you have somebody that is severely anxiety, again, this is not the time to do education, new information, new teaching. It's just going to add fuel to the fire. When they are in a full panic attack, clients are irrational. They're unaware of potential harms. If somebody is in a full panic attack, this is somebody that can run into traffic and get hit by a car. These usually last 30 minutes, 15, 30 minutes. You need to stay with the client while they have a panic attack. You want to move them to a quiet room that's non-stimulating. You want to use a calm, reassuring voice, reassuring that it's going to pass, that they're going to be safe, but you need to stay with them. Remember, for your self-awareness, anxiety kind of is contagious. And we ourselves sometimes get anxious, and that can kind of affect our clients. So we need to really remain calm and in control of our situations. And we can do some pharmacological treatments. Short term, we can do benzodiazepine, especially if somebody is an acute anxiety attack, but really should only be used for a few weeks. Actually, I think the FDA says like 7 days, but here nor there, your book says short term, 4 to 6 weeks max, due to the risk of abuse and dependence. Medications are just temporary. The big thing is helping them with coping. So our different anxiety disorders, we can have agoraphobia, which this client is going to get like fear, apprehension, when they're leaving the house, when they're like in the subway, close quarters, things like that. We have panic disorder, which we'll talk about more, generalized anxiety disorder, and social disorder. So anxiety disorder overview, highest of all mental health disorders in the United States, more common in women, people under the age of 45. Um, we can also have selective mutism within this, anxiety disorder due to other mental health conditions. We need to do the substance induced. So if they have substance use and anxiety, that would be that dual diagnosis. We can also have separation anxiety disorder. Um, our biological theories related to anxiety. So there are some genetic theories that talk about a hereditary component, especially amongst first degree relatives. With generalized anxiety disorder, we note that there is a very strong familiar pattern with it. We have some neurochemical theories when we think about GABA, which is your primary inhibitory, which relaxes us. So if we have a dysfunction in GABA, that can be linked to anxiety. If we have excessive amounts of norepinephrine, that can increase our anxiety. And then we know serotonin's our happy drug. And if that receptor is off, that can have anxiety, aggression, and mood issues. When we look at psychodynamic theories, we have Freud's psychoanalytic theory, where he viewed anxiety as an internal conflict between our id, ego, and superego. And he felt that people unconsciously use defense mechanisms to manage their anxiety. An overuse of defense mechanism is usually leads to poor emotional development and difficulties with problem-solving skills. And then we have our interpersonal theory, which is Harry Sachs Sullivan. That belief was that anxiety originates from interpersonal relationships. So if somebody had poor caregiver bond, unrealistic expectations, or high societal pressures, they're going to be at risk for having it. And that high anxiety disrupts our ability to communicate and problem solve, and increased vulnerability to anxiety disorders if we have communication and problem solving skills reduced. Hildegard's theory, she looked at anxiety both in interpersonal and physiological realms. And she noted that nurses can help clients by addressing both their emotional and physical symptoms. She's the one who developed your therapeutic communication techniques. And the better our therapeutic communication is, the better we can help our client when they're anxious. Then there's some behavioral theorists that feel that anxiety is learned through experiences, and we have maladaptive behaviors that can be unlearned through therapy. So they were the ones that really wanted to do exposure therapy and cognitive behavioral therapy to help the client identify and modify their behaviors. Cultural considerations. So some cultures manifest anxiety through somatic symptoms, right? And those somatic symptoms are the things that we find no organic cause to. So somebody who has headaches without having anything wrong, somebody who has back pain and you were taking x-rays and CAT scans and MRIs and there's nothing that causes the pain, gastrointestinal distress, right? These are all things that we can complain about that we really can't find a cause for, and then we say they're somatic. We know that other cultures may attribute anxiety to maybe spiritual or environmental causes. We want to make sure that we're avoiding stereotypes. Um, and we realize that every individual's experience with anxiety is unique, even within their cultural group. We want to make sure that we're respecting beliefs, understanding a client's personal and cultural explanation of anxiety can improve communications and treatment outcomes. And again, holistic care as always, right? We want to incorporate culturally sensitive interventions such as spiritual practices and traditional remedies that as long as they're not going to hinder care, they're going to help support the client. So, what's our treatment going to be? Effective treatment for anxiety disorder typically involves a combination of medications and therapies. That's better than just one or the other. So, when we talk about medications, we can use our SSRIs. Remember, it takes a few weeks for those to become effective. They also have that black box warning for people that are younger than 24. We have that increased risk for suicide. Other medications that are used in anxiety, we can do benzodiazepines, but remember they have a high risk for dependence. We can use beta blockers that reduce those physical symptoms like heart rate, but we need to be mindful if our patient has, if they're on certain respiratory medications. And then we can also use Buspar, which is a non-addictive anti-anxiety medications. We can do cognitive behavioral therapy, such as positive reframing. So, trying to replace those negative thoughts that we have with more positive, rational messages. An example would be if somebody has a negative thought, my heart is pounding, I think I'm going to die. We can reframe it as this is just anxiety, I can handle it, it will pass. Clients can write these messages down, keep them on hand, and when they start to feel their heart pounding, pull them out and review them. We also have that decatastrophizing, where a client needs to reframe the worst case thinking. So, what's the worst that could happen? Is this really likely? Could I survive that? And we can also use sometimes thought stopping techniques where, if you start to feel that way, splash some cold water on your face, snap a rubber band on your wrist, and things like that. We can do assertive training, which can help the clients gain control over life situations. Using I statements. I feel frustrated when you interrupt me. I need 30 minutes in the evening to relax. Age-related considerations for anxiety. So when we talk about childhood, we have some childhood anxiety disorders like selective mutism. It's usually diagnosed in children before the age of 18. It can persist into adulthood, usually being social anxiety disorder. We can have separation anxiety disorder. Um, it's usually occurs in children. That can contribute to long-term anxiety. We can have early onset anxiety disorders. The median age of that's about 12. We can have phobic disorders, which tend to be most stable over time. Generalized anxiety and panic disorders in kids often show remissions and exacerbations. Anxiety can increase the risk of suicide in youth. Highest is seen in those with social anxiety disorders. Late onset anxiety disorders, when we have new onset of anxiety in adults, it's usually linked to depression, dementia, physical illness, or medication toxicity and withdrawal. Common late flight anxiety disorder could be phobias and general anxiety linked to depression. Panic attacks in older adults also could be associated with depression, but really need to rule out that there's no underlying cardiovascular, GI, or pulmonary disease. These guys can also have rumination thoughts late in life where they become kind of obsessed with these ruminating thoughts. Treatments in our older adults, first line therapy, SSRIs. Anytime we medicate our older adults and even our pediatric patients, we want to start with low dose. And benzodiazepines are not recommended in older adults. Increased risk for falls, which increase risk for hip fractures, which decreases life expectancy. There's also a potential for dependence and cognitive impairments with benzos in elder adults. So our health promotion, we want to do effective stress management strategies. So we want to make sure that we're maintaining a positive attitude, believe in yourself, believe in your ability to cope, right? That's what we need to teach our patients. We need to accept what they cannot control and let go of unnecessary worries. We want to help them express their feelings, talking, laughing, crying, just a true, healthy emotional expression. We want to practice relaxation techniques with them, like meditation, deep breathing, guided imagery. Set realistic goals, right? We need to make sure that they're engaging in meaningful activities that bring fulfillment. We want to make sure that they're maintaining a healthy lifestyle. So balance diet, regular exercise, adequate sleep, limit caffeine and alcohol. For health promotion, we want to understand anxiety. And we know that it's not inherently negative, right? It's a warning sign that stress management may need to improve, and even positive life changes can come out of it. We can have positive life changes that can trigger anxiety. So, effective coping is key. And we need to remember that the role of medication is to relieve excessive anxiety, but medication is not a permanent fix. These clients need to learn goal. Um, the goal is learning coping skills and stress reduction. When we talk about panic disorder, so panic disorder is recurrent, unexpected panic attacks. It persists for a month, at least a month, and they need to have worry for most days. Significant behavioral changes due to fear or future attacks. No environmental triggers for the initial attacks. 50% of cases include agoraphobia. The clinical course usually it peaks in late adolescence to mid 30s. Symptoms in the panic is going to be 15 to 30 minutes of rapid, intense, escalating anxiety. They're going to have sudden emotional and physiological panic response. Fear recurrence leads to avoidance behaviors. Severe cases may result in being homebound or limited travel. When we talk about agoraphobia, this is going to be fear of open or public spaces due to these panic attacks. So a lot of times we think about this as somebody that leaves their house. It's because they're leaving their house and they're going into open or public spaces. Some of these clients will remain homebound, where others will limit their movements, and it can exist with or without panic attacks, agoraphobia. Behavioral impact, primary gain, anxiety relief through avoidance, secondary gain, attention and care from family members. Family may unknowingly reinforce these negative behaviors. Treatments, we're going to be looking at cognitive behavioral, deep breathing and relaxation, medications, benzos, SSRIs, tricyclics, and sometimes antihypertensive agents for those alpha blockers. So when we're doing our assessment, there's a lot of anxiety rating scales. Your book looks at the Hamilton rating scale for anxiety. You want to get their history, right? So have they sought treatment for this before? How are they reporting it? Do they have any identifiable triggers, or does it just come on? Or their appearance, right? Do they appear normal? Do they appear anxious? Their speech may be rapid, high-pitched, or loud. They may have difficulty sitting still. They might have automatisms where they're finger tapping, jiggling their keys, twisting their hair, something to that effect. Their mood and affect, they might be anxious, worried, tense, depressed, sad. They may report depersonalization, feeling disconnected from themselves, or derealization, feeling like their surroundings are unreal. Their thought process during an attack is usually overwhelmed, disorganized, irrational, and they might even have suicidal thoughts. Between attacks is usually excessive worry about future attacks. Their sensorium and intellectual process during the attack, they might be confused, they might be disoriented, they might be unable to process environmental cues. Post attack cognitive function is going to be normal. Judgment during the attack is going to be impaired. This can lead to unsafe actions like running into traffic. Insight develops after education about their disorder, and initially a client might feel really helpless and out of control. Self-concept, usually we have a lot of self-blame. I was so weak and out of control. Loss of identity. I used to be happy and well adjusted, and now I'm not. They could be in a constant worry about attacks. This can lead to avoidance of activities that they once enjoyed. Roles and relationships, panic disorders really disrupt your social, occupational, and family life. You might avoid places, people, and events that are linked to past attacks. And you may escalate to extreme avoidance to the point of quitting work and staying at home indefinitely. Physiological and self-care concerns, these clients may experience sleep disturbances and changes in their eating patterns. Some clients might lose appetite altogether due to stress, and other clients might turn to overeating as a coping mechanism to deal with stress. So we did our assessment. Now we're going to be doing our priority setting, diagnoses, concepts, and outcomes, right? So as always, number one, we want to make sure that they're not at risk for injury or self-harm. They might have ineffective coping, ineffective role performance, sleep disturbances, nutritional things. So our outcomes is always going to be, that patient will be free from injury. The patient will get 6 hours of sleep a night. The patient's going to verbalize a sense of control. And then we talk about what are the actions to get these things to happen, right? So if we're looking at promoting a safe environment, right, we want to make sure that we're providing that safe environment, that we have privacy, especially during our panic attack. We want to make sure that they're moved to a quiet, less stimulating environment. We want to stay with the client when they're having the panic attack, offer reassurance, use a calm, soothing voice, maintain control until the client regains self-control. We want to use our therapeutic communication. We want to make sure that we're establishing rapport. We want to use calm, simple communication, allow movement if the client needs to pace, walk with them if necessary, avoid unnecessary touching. This could be misinterpreted as a threat and put you in harm's way. Once anxiety subsides, use open-ended questions to encourage discussion. Example, it seems anxiety is subsiding. Can you share what it was like a few minutes ago? When we talk about managing the anxiety, we want to do teaching and encouragement of relaxation techniques. So this could be deep breathing, guided imagery, progressive relaxation, which that's when we tighten and release different muscle groups in our body. We can use cognitive restructuring, such as reframing the anxious thoughts. We can provide the client and family with education. So teach those calming relaxation techniques. Explain the physiological effects of anxiety. and how the role of their therapy and medications can help that. Encourage them to have regular exercise so that way when we have that release of endorphins, um, they're going to be okay with it. Education on medication, so dose, regimen, side effects, interactions, um, and that these treatments that we're doing are help manage it. It's not going to cure the disorder. This is just more patient family education, right? So deep breathing, teach breathing, guided imagery, progressive relaxation, discuss positive coping mechanisms like mindfulness, journaling, cognitive restructuring, encourage exercise to help metabolize adrenaline, reduce panic reactions, and boost those endorphins for overall well-being, emphasize medication adherence, stress the importance of maintaining the prescribed medication regimen, encourage regular follow up with their healthcare providers. Teach time management techniques, using a to do list, crossing off the completed tasks to give them a sense of accomplishment. Practicing saying no to prevent overwhelming commitments. And then promote social support and community involvement. We want to encourage maintaining contact with supportive friends, families, and organizations, and recommend participation in support groups for anxiety management. So this is just your evaluation, right? If we did something for coping, is your client using their coping skills? Phobias. So, phobias are persistent, intense, and an irrational fear of a specific object or situation, causes significant distress, and interferes with daily function. Fear often not linked to past negative experience. So, what do we have? We have agoraphobia, fear of being outside. We have specific phobias, and then we have social phobias, which can be our social anxiety disorder. That's anxiety triggered by social or performance situation. We can have types of specific phobias. So we can have fear of animals, insects, blood products, injections. The onset and course specific phobias typically begin in childhood and adolescence, persist into adulthood, 80% remain lifelong. Social phobias typically start in mid adolescence. Severity fluctuates with life stress and demands, and it could lessen with age. So, our treatment of phobias, behavioral therapy works well for all phobias. Behavioral therapy helps clients understand their triggers and their responses. It teaches relaxation techniques, goal settings, and coping strategies. It encourages self building, self control, positive reframing, assertiveness training. When we talk about systematic desensitization, this is a gradual exposure to fear object. It's gradually done in a safe environment. It gives a step-by-step approach to reduce the anxiety with increasing intensity of exposure. So it could start out as afraid of flying. And first, maybe we're just going to talk about the imagery of a plane. And next, maybe I'm going to hold a small airplane. And then maybe I'll visit an airport. And then maybe I'll sit in the plane. And eventually, we're going to take a short flight. Flooding is a rapid desensitization. Flooding is intense exposure to the phobic object until the anxiety subsides, based on the idea that once worse fears are confronted, fear in itself is diminished. This causes highly anxiety inducing and can only be conducted by a trained professional because of the physiological changes that can happen with it. We can also use medications for these. Benzodiazepines really should not be used. They're short term, and clients do not learn how to cope with their phobia when we use benzos. SSRIs are going to be your first line treatment for long-term management. And then we can do things like beta blockers to help manage the physical symptoms such as rapid heart rates, sweating. A lot of times we use beta blockers with clients that have performance anxiety. Sorry, I don't do the questions on the online lectures. All right, so self-awareness issues. Remember that working with clients with anxiety disorders can give us anxiety. We need to make sure that we avoid assuming the clients can simply just calm down and control their anxiety at will. We need to recognize that anxiety disorders are real medical conditions, not just the client's overreaction. We need to make sure that we're empathetic, patient, and non-judgmental. The nurse needs self-awareness. The nurse must balance professional responsibilities with their own emotional well-being, acknowledging that stress and anxiety can affect healthcare providers too. We need to develop self-care strategies to maintain emotional resilience for ourselves, especially while caring for clients with anxiety disorders. Understanding the client's experience, the client with anxiety disorders are awfully high functioning individuals in other aspects of their lives. They can recognize their symptoms as unusual, but feel powerless to control them. Anxiety creates frustration, helplessness, and fear, leading to avoidance that disrupts your client's daily life. And that is the end of this lecture.